Good morning or good afternoon for those joining us from the East Coast. I'm Dr. Joe Lamb, and I'm coming to you from the Personalized Lifestyle Medicine Center by Metagenics in Gig Harbor, Washington. This is part of our ongoing series. We have 3 of these. We have one on women's health. We have one on cardiovascular health, and we have one on gastrointestinal health. But this is going to be a 5-part series, Thursdays at 11 a.m. for 4 more weeks after this. Today, we're talking about a woman's rhythms and life cycles. Next time, we'll talk about nutrition for optimal woman's health. The time after, we'll talk about bioidentical hormone therapy. At the next visit or session, number 4, we'll talk about nutritional and botanical support for women's health. And finally, we'll talk about self-care and stress management in our final session. So for all of us, for men and women, there are clearly cycles in our lives. And those cycles are marked by times of health and times of illness, times of pandemic. We've all been faced by a very interesting year. And it's become really rather clear to me that the journey that we're all on is one of understanding our health as more than just the absence of disease. Wellness cannot be measured by disease biomarkers. We can't just say I'm healthy because I don't have risk factors. And we can't say I'm healthy because I don't have an established disease. There's more than that. Wellness is being able to do all the things that we want to do in our life. And it's not just a destination, it's kind of a journey, because you can get to a point where, you say, I'm in my 20s and my wellness is measured by my ability to do X. And in your 30s, it may be that you want to do more. But it may be that by the time you're in your 50s and your 60s, you'll want to do something different. Or, you won't want to be playing competitive sports, so maybe you won't be working out as hard. So wellness needs to be measured by something unique, by the ability to function, whether that's metabolic or physical function, kind of looking at the microscopic level, or whether that's physical function in terms of, what we see with a macroscopic look, like how well we move, what our balance is like, what our emotional function is, what our cognitive function is. And then finally, there's a component of function called behavior. And, what is behavior, but really kind of the outward expression of kind of the more or less successful inward integration of your mind, body, and spirit. Because, the things that we do are our behaviors, and they're influenced by the other 4 areas of function: metabolic, physical, emotional, and cognitive. And our behaviors are truly adaptive. We've successfully integrated all the components when our behaviors allow us to do what we want to do in the world. Now, all of us are faced by challenges. We're faced by time challenges. We're faced by work challenges, relationship challenges, environmental challenges, as we've seen with this pandemic that we've experienced. So the big question becomes one of how do we incorporate change? In kind of the world of behavioral science, and looking at how to get people to make change in life, there's been a lot of devaluing of motivation. And I think that's because we've looked at motivation in really kind of the wrong way. It's not really motivation if I scare you. If you come in for an office visit and we talk about your health and I scare you more than I help you, then we really haven't gotten to a very good point in time. We haven't gotten to a growth perspective. So I think it becomes important for us to start saying motivation isn't fear. It's not all the negatives. It's not being driven by somebody else. BJ Fogg and others have talked about making behaviors simple and tying them to a good trigger. So an example, if you're not flossing your teeth, but you are brushing your teeth, then the behavior that would maybe be requested to start would be just putting the floss on the counter in the bathroom every time you take your toothbrush out. And the concept being, well, that's the simple behavior that you can do. You tying it to the trigger of something that you already do, and you adopt the behavior of putting out the floss. And pretty soon, you'll adopt further behaviors, simple ones that step upon that, like, well, I'm going to floss one teeth, or I'm going to floss all my front teeth, or I'm going to try to floss all my other teeth, and have it become something that you do. But really, those sorts of changes, I'm not sure if they're lasting, and I'm not necessarily sure that they're functional. If you have to make all of your choices simple, then you lose the potential for big steps forward. To me, making lasting behavioral change, on this journey to women's health, making lasting changes would be about doing things that fit with your goals. I think one of the big obstacles on our journey to achieving full wellness is the brokenness of our dreams. When we were little kids, maybe some of us wanted to be president, maybe some of us wanted to be a soldier, maybe some of us wanted to be an actor or an actress, a teacher, a physician, a paleontologist, a sports figure, the best volleyball player, perhaps, or the best ice hockey player, or the best football player. We had all these dreams about what we wanted to do. But if you think about those dreams, one of the things that jumps out at you as you think about those dreams is no child ever said, I want to be the person sitting in the fifth row back, fourth cubicle over, and I don't want anyone to know my name. We want it to be heroes. We want it to live large. We want it to contribute. A lot of it was, from a child's perspective about our inward life and, not so much about our communities. But there was something Jungian, there was something archetypal about those types of dreams. And unfortunately, for many of us, as we pass through school, we start hearing that we're not enough when we maybe don't get the grades we want. Maybe we aren't up to doing something academically, or, maybe we're not up to being the best of athletes, or, maybe we are. And unfortunately, we haven't had the resources, like we didn't get to go to college because of financial circumstances or whatever it may be. And so it becomes kind of a limited view that we start taking of ourselves. And there's an awful lot of people who, just because, they weren't supported, they weren't loved, they weren't valued, have kind of lost touch with that identity, defining who the you is. your authentic self, your soulful sort of presence that gives you the ability to reestablish what you wanted to do. Just because we don't have those kind of concrete destinations for what we wanted to be when we grew up and we didn't get there, doesn't mean that we still don't have those same Jungian drives, those same archetypal drives to be a hero. And what it comes down to is learning who we are and redefining that so that we know something important about who we want to be. And maybe that hero is someone who just shows up in their life and, relates to other people with reverence and respect and, makes those sorts of changes. So, finding that touch point, years ago, I went to the Comprehensive Cancer Care Conference given by Jim Gordon's group, the Center for Mind-Body Medicine in Washington, D.C., and I was struck by people talking about cancer as a gift because it allowed them to kind of heal that brokenness within them and decide what they wanted to do. It made them force an evaluation of their lives, to face what they wanted to do. So I think that, reestablishing that, kind of recreating, revisioning, doing all of those pieces to find out where we're going to be is so important. And functional medicine, its philosophy helps us by allowing us to kind of jump in and witness the changes that are taking place in our lives and gives us the information. We can start having an appreciation for the fact that we don't just wake up one day being menopausal. It's not like I had normal functioning and one day I don't, and now I'm a menopausal woman. No, it's a period of change and transition. And what can we learn about that transition? How is it an interaction of our genes and our environment and, everything that's taking place with us? And how do we manage those cycles? A woman's health is uniquely special because there really are cycles that we see so much more dramatically. The monthly cycle in preparation for, ovulation, having an egg ready to be fertilized, for a woman starting in her early adolescence, right up through her 50s, fertility requires hormonal changes in hormonal cycles every month. Men have, their childhood, and then they have the period of puberty, and then they pretty much stay the same, though there is an andropause and kind of a dropping off of testosterone levels late in life. But for women, it's dramatic. Each month there's a change. There's a physiology building up to ovulation and preparing the uterus to receive a fertilized egg. And then there's the period of time, if the egg isn't fertilized, the changes that take place. Or if it is, all the changes of pregnancy and how much different hormonally that is. And then, as the egg supply starts dropping off, as a woman ages, as there's kind of a congruence of building up more, or confluence of building up more environmental toxicities, maybe nutritional compromise, maybe a loss of function, we start moving towards perimenopause, that kind of period of time that may start as early as the 40s and lead right up into the 50s. That, average menopause, that 1 year period preceding or the 1 year period after the last menses is menopause, and perimenopause is the time preceding that. And women have that typically at age 50 to 51, but one of the things that we're seeing is an increasing number of women with what's called primary ovarian insufficiency, kind of this early onset of running out of reserve. And so menopause hitting earlier. And, I've recently seen a woman as early as her 20s, for probably environmental reasons, perhaps for genetic reasons. We couldn't identify any sort of hormonal pituitary issues, but the loss of this function coming in the 20s. So the cycles are changing. One of the interesting things about perimenopause and menopause is the fact that, we've really thought about this and treated it since the onset of synthetic estrogens and synthetic progesterones and the ability even, to isolate and collect the bioidentical hormones. We've kind of treated this period of a woman's life as if it were a disease process. But it's not so much a disease process as a consequence of probably our longer life expectancies. If you think about the fact that for most of human history, we probably didn't live long enough to make it into our 50s, a woman had an ovarian reserve, enough eggs coming to fruition, enough of them that there was that there'd be a driver for the hormonal cycles all the way up through into the 50s. And most women never lived to get there. And now we live well past that. And from an evolutionary perspective, there hasn't been enough time to evolve, and have evolutionary pressure drive having ovaries that are bigger or have more follicles that will give rise to eggs so that reproductive function goes on longer. And we probably don't want reproductive function to go on a lot longer. I mean, women in their 50s and 60s are living different lives than they did when they were in their 20s and 30s, and they don't need to be able to reproduce. But what does happen and what changes dramatically are the hormonal changes that take place. Anytime you think about whether we call something natural or not natural, whether we call something a disease or not, one of the things is we have to kind of couch that description in the ongoing kind of history of how we viewed it. And it wasn't until the 1960s with the introduction of oral contraceptives and the ability to have hormones potent enough to overcome the normal monthly cycling and hormones that we could easily give during the postmenopausal years, perimenopausal and postmenopausal, and control ovulation and control cycles and all of those. It wasn't until we could do that that we had a lot to do for women's health in that regard, or to manage what was becoming recognized as something that needed to be managed, and managed with a drug kind of fitting into our allopathic, or a replaced hormone fitting into our allopathic model of, one bug, one drug that we learned from infectious disease that kind of led us to name a disease, to blame a disease, and finally to tame a disease, and to do it with a pharmacologic approach, and no real recognition for what lifestyle means in that regard. And so, by the time I was in private practice in the early 90s, as what I thought was a fairly aware allopath, the things that we were doing were giving women Premarin and Provera, Premarin being conjugated equine estrogens. So conjugated just means metabolized. Equine means from a horse. And estrogen, clearly the hormone that circulates in a woman. But in this case, we were collecting these hormones from horses, from their urine, from pregnant mares when they were making lots of estrogens during pregnancy. And we'd collect their urine and we'd isolate out the hormones and we would give them to women. And we paired that with a strong synthetic progestin. So progesterone is the name of the hormone. Progestin is the name of, well, progesterone is the naturally occurring hormone in women. And progestin is that whole class of chemical compounds that are similar. And so, many of those are modified versions of the progesterone. And so the class is called progestins. The class of estrogens is called estrogen. And then the specific estrogens, the ones most prevalent in the woman during reproductive years, it's estradiol. Later in life, including in perimenopause and menopause, estrone becomes more dominant. And then estriol is the third one. And so as we look at these hormones, we started giving them. And, one of the drawbacks to the conjugated equine estrogens was they were in their kind of metabolized or conjugated form so that they could be excreted. So not typically a form that, women would have circulating in their bloodstreams. And there were some metabolites that were unique to horses and not to women. So it wasn't a very strong pattern, not necessarily things that were the best match for a woman's body. So the question arose in the 90s was, did it make sense to have, hormone replacement therapy during perimenopause and menopause and postmenopausally, and what were the health benefits and the health risks? Studies suggested that there were benefits in terms of cardiovascular disease, that there were benefits in terms of osteoporosis, that there were benefits in terms of cognition and mood and, sexual function, in terms of, vaginal health, not having an atrophic vagina, kind of a dry vagina, but, skin was in better condition. All of these things were thought to be related to continued replacement of hormones. But then there was the downside: increased breast cancer, increased uterine cancer. And, and were we really, what was the risk? What was the benefit? And so a large study was done, the Women's Health Initiative, and the Women's Health Initiative came out with, the study started in the late 90s and it was terminated in the early 2000s. And the reason the study was terminated was because the safety committee was looking at data that seemed to suggest that women were being killed by taking the combination of Premarin and Provera. There didn't seem to be savings from a cardiovascular perspective. It didn't seem to be reducing cardiovascular disease. And on the flip side, beyond cancers, beyond, breast and uterine cancers, it seemed to be causing a lot more of kind of unexpected, cerebral vascular disease, an increased risk of stroke, and an increased risk of hemorrhagic stroke, as well as there was more venous thromboembolism, so blood clots in the legs going up to the lungs and causing pulmonary emboli, and blood clots thrown to the lungs and causing sudden death. And so the study was discontinued, and suddenly in the early 2000s, it became, well, we don't treat women for this because there's not a cardiovascular benefit in terms of coronary artery disease. There's more risks. There's the cancer risks. And, if we really want to take care of bone and do some of these things, or if we want to take care of the symptoms, we can use the bisphosphonates for bone, or, for some of the vasomotor symptoms like the hot flashes and those sorts, or the mood, well, we've got the selective serotonin reuptake inhibitors. And so we thought we had some answers. But as we looked at the data on those studies, one of the things that jumped out was, while it was a good study design, and while you can clearly understand why they made some of the rules that they made about which patients they really treat and not treat, the rules that they made influenced the outcome and may actually have been related to the outcomes that were unexpected. So one of the rules that they did when looking at this study was they talked about, let's take women who are having persistent symptoms. So, we want not just women having a relatively easy perimenopause or menopausal period. We want women with continued hot flashes and night sweats and irritability and those sorts of signs. And interestingly enough, studies have shown that a lot of those symptoms are worse in women who are less healthy. So they may have been kind of selecting by taking the sickest of the sick, or the most symptomatic of women going through perimenopause and menopause. They may have been selecting out a group of women with less healthy lifestyles and selecting out a group of women who had other associated illnesses. The other piece was they wanted women who were relatively naive in terms of previous use of hormones. So, they didn't want someone who during perimenopause had been on a low dose oral contraceptive. They wanted women who had been, no estrogen or progesterone for years in order to, not have the study influenced by previous use. And so what they ended up with, interestingly enough, was a group of women who were older, many of whom weren't all that healthy, some of whom, like the average age was almost 5 years out from menopause when they started the hormonal replacement therapy. And so one of the things that became very clear as the data was evaluated was that maybe we were treating not the group of women that we thought we were treating, and that maybe there was a window. So if you take a group of not so healthy women, you let them experience perimenopause and menopause for like 5 years, all of those changes, all the development of inflammation, because estrogen's a nice anti-inflammatory, and when production drops off, there's more inflammation. These women may have been well along their way to catching up with men in terms of heart disease. So, and indeed, the study suggested that women started closer to the time of their last period may actually have what should we take from this data for a healthy woman closer to menopause? Can we kind of generalize the findings of the study? It became clear that you probably can't. So thinking has switched back, 1990s thinking every woman, of a certain age and of a certain physiology, i.e. premenopausal, perimenopausal, late 40s, 50s, all of them get Premarin and Provera to suddenly the Women's Health Initiative, and right afterwards, no one gets it. And now we're at a point in time where let's make the right decision for a woman. What are our treatment goals? Are the symptoms particularly bad? Do we treat those? Are our goals more kind of anti-aging, and where do we fit in? And it offers us the opportunity to start talking about, recreating, like, so are we at an optimal weight? Do we have insulin resistance managed? Where is the thyroid? And, when you think about like a hierarchy of hormones, at the very top of the hierarchy, we've got the ones that help us cope with stress, are, epinephrine and adrenaline and cortisol and the neurotransmitters, dopamine, serotonin, how we kind of signal and stay in the world and show up. And then the level below that, we've got insulin, which helps provide us energy, and the cortisol, which helps us come down from stress and, interacts with the insulin. We've got the growth hormones, we've got the thyroid hormone, and then finally we've got that level of hormones that help us reproduce. And, they bring us wellness, and, there's all sorts of cross connections between these. But, it's very difficult to manage, hormonal levels for a man or for a woman. If you haven't managed their thyroid and their insulin first. So, the opportunity becomes one of saying, let's address lifestyle, let's find the right diet, let's create an exercise program, let's create a mind-body program, let's do some visioning exercises to see what it is that we really want to do, and then have a discussion about where do various hormones fit in? Is it bioidentical hormones? And what do I mean by bioidentical? Well, if you think about the natural hormones circulating in a woman, we don't have a source of those outside of a woman. So if I want to have some to give to a woman, I either need like a plant that makes them, or I need to make them in a test tube, or I need to be able to get them from an animal and get exactly the ones I want. And at the moment, we can make kind of, chemically synthesize some of these, like we can make estradiol, we can make various synthetic progestins, we can make synthetic estrogens, but, those, we suddenly start saying they're man-made because they're synthesized in a lab, but they've got the structures perhaps of the natural structure. And then, but, plant estrogens, they're not estradiol or estrone or estriol. They are different. And if you take one of those plant sources so that you don't have to take an animal source and then modify it, well, it's synthetic. So instead of using the word, synthetic is kind of synonymous with unnatural, synonymous with not good for us, we use the word bioidentical to say, well, even if it's a plant source and we chemically modify it a little bit, if it's exactly the hormone that a woman would have seen, then this is a good thing. So we have bioidentical hormones. Some of them are made by pharmaceutical companies. Some of them are, you can get at a compounded pharmacy. The flexibility of a compounding pharmacy is increased dosage ranges, like micronized natural progesterone only comes in 100 and 200 milligram dose as a prescription available from a pharmaceutical company. But, your compounding pharmacy can come up with capsules of 25 or 50 milligrams or 110 milligrams if that's the kind of flexibility and adjustment we need. And, we're so lucky here in Gig Harbor to have a new compounding pharmacy, Harbor Health, and that gives us all sorts of options. And, and the ability to have estrogens like in a cream form and have the testosterone in that form, and DHEA and progesterone, or progesterone by mouth, or you can get a pharmaceutical patch of estrogen, because we now know that, giving estrogens and having it absorbed through the skin is better for us than taking it by mouth. And so we can make these choices to kind of match up a woman's cycle. In a study we did when we were using a natural botanical as opposed to bioidentical hormones, we were studying Siberian rhubarb and riponticin and ripontogen, which are the active ingredients in our product at Metagenics Estravera. When we were studying that product, it was very clear that the women who were coming in, many of them were well past menopause and still symptomatic, and they smoke and they drank and they were overweight and they were insulin resistant. So all of these things become part of what we can do as we look to restore kind of that orchestration to changing rhythms and preserving good health, having anti-aging functions, and keeping a woman completely participatory in her life. So thanks a lot. Coming to the end of today's talk. We'll be back next week to talk about optimal nutrition for women's health as we move forward. A couple upcoming events on the 24th of April. Dr. Michael Stone, Susan Buell, and Courtney Suter and I are doing 90 minutes of recreating envisioning here on Facebook Live at Joseph Lamb MD at 9 a.m. Pacific time. That's on a Saturday morning, so we hope you'll join us and you'll hear about some unique opportunities that may give you the opportunity to travel with us to Helena, Montana in July of this year for our 5-day functional medicine journey. So look forward to seeing you next Thursday. Also, we have our ongoing Lunch and Learn series, and next week is the third Thursday. So we'll be having a lecture that day on minimizing cardiovascular disease risk with functional medicine. But we're also going to be starting our cardiovascular series coming up in a relatively short period of time. Let's see, our cardiovascular series kicks off on the 19th of April, and our gut health one kicks off on the 26th of April. So I hope you'll join us for some of these educational events. We'd really like to see you there, and I hope you have an awesome day. Thanks a lot. Bye-bye.